Welcome back. This is week 4. The subject for this week's lectures is eye, ear, nose, and throat disorders. These are the learning outcomes. At the end of this week, you should be able to define what is meant by EENT problems, list the various diagnostic triads, describe the key features of each of the diseases that are covered in the diagnostic triads. Review the labs that are pertinent to this week's disorders. And then at the end, we will conclude by reviewing the significance of physical findings mentioned in this. Because remember, this is part and parcel of the general diagnosis section in board's part 2. The definition we're going to use is that of sore throat. Our index patient is the eldest of the 3 Sikalot children. This is Chloe Sikalot. She's 16 years of age. She is complaining of sore throat, which is part of the eye, ear, nose, and throat discussion. And sore throat is defined as the unpleasant, subjective sensation or of discomfort or difficulty in swallowing. Now, my approach for the rest of the symptom-based topics is a combination of the 4 diagnostic approaches we have talked about. We talked about pattern recognition. I'm going to use the concept of an illness script, and I gave you an example of what an illness script is. Periumbilical pain in a child radiating to the right iliac fossa, followed by fever and vomiting is the illness script for, if you recognize the pattern as most of you would by now, acute appendicitis. So we're going to be using the illness script to help you to trigger the diagnosis. We're going to focus on the 3 most common or important causes for each of those diagnostic triads. This is the epidemiological approach. We're using a focus on what's common or important rather than a list of 25 causes of eye pain. We're also going to use the algorithmic approach. You can see from the chart on the right, which is taken out of differential diagnosis to do specifically with eye, ear, nose, and throat problem. The steps are 1, 2, 3, 4, 5, 6 steps. You start off first with, is the complaint of the patient red, painful eye? If the answer is no, you go to the next level. Is there blurred vision? If there's no blurred vision, you go to the next level. Is the problem an earache? Yes. And then we go, is it related to otitis externa? If there is no earache that is worse on pulling on the ear, then you go down to the next level on the earache. Possibility of otitis media. On examination, is the tympanic membrane red and bulging? No. Then let's consider the possibility of TMJ dysfunction. Is the earache worse on opening the mouth? Yes. And then we go down and see how many of the classic features of TMJ did this patient have. So that's the algorithmic approach. And then the hypothetico-deductive approach, otherwise known as the Sherlock Holmes approach, is cue generated. Again, the cues here would be painful red eye, blurred vision, earache, nasal problems, sore throat, or swelling in the thyroid region. If it's none of those, then we have one last category. Is it these 3 things? So this approach is a combination of all 4 of the diagnostic approaches. As I said, I'm not going to tell you which is going to work best for you. You will find out as we progress through the course that, yeah, illness script works best for you, and therefore you will be concentrating on the right side of this page so that when you see uh, the complaint of blurred vision, that is gradual onset, and there's cloudiness of vision, yes, I recognize this pattern. This is a cataract. Okay, so the final decision is yours, but I think most of you are going to be comfortable starting off with the pattern recognition approach. So here is it in a lot more detail, the pattern recognition. You can pick any one of these. Let's pick another one. A runny nose with swollen nasal mucosa because the patient is complaining of nasal stuffiness. When you see that, then you are dealing with rhinitis. We don't need to, at this stage, discuss distinguishing between viral rhinitis or an allergic rhinitis, or less common than both viral and allergies might be a bacterial rhinitis. Let's say the problem in the EENT region was the complaint of a lump in my throat, and then you find in your examination bilateral exophthalmos goiter and unexplained weight loss. The patient's diagnosis is, or hypothesis is, Graves' disease, and then you use that hypothesis to then go and look for specific signs that would go along with Graves' disease, like tachycardia, like weight loss, like fine tremors of the extended hand, and then things like anxiety or loose stool. You don't have to have all 10 of the classic findings for Graves' disease for you to think about this, and then you go through the process of what would be the diagnostic test. The diagnostic test or group of tests would be your thyroid function test, and then you're looking specifically for elevation in your T3, T4, confirmed by a decrease in your TSH. Any questions about the approach we're going to be using? If not, let's start with the first diagnostic triad, painful red eye. As you'll find out, when I start off with a diagnostic triad or hub, the first item or two or maybe three would be focused on red flag situations where you need to recognize that this painful red eye on the left side is actually due to acute glaucoma, not chronic glaucoma or any other cause of a painful red eye, because this needs to be taken care of with some sense of urgency. Acute glaucoma, which you've done already when you did EENT anatomy and physiology, is also known as closed angle glaucoma. There is an acute blockage of the outflow of intraocular fluid, which is secreted by the ciliary epithelium related to the ciliary body. And then this flows behind the iris and in front of the lens, passes through the pupil in the iris, and then goes into the corner at the angle between the cornea and the sclera. There is a canal called the canal of Schlemm. There is a venous plexus there in which the intraocular fluid is going to drain into the venous system and then go back to the heart. The presentation for acute glaucoma is classic. Sudden onset of a painful red eye. It hurts, probably on a scale of 0 to 10, 6 to 7, it's uncomfortable. They may come to you, they may go to the urgent care. If they come to you, you should be able to, one, recognize that there is redness around the cornea. You should be able to palpate with your fingers, and I'm hoping you were taught how to palpate eyeball pressure with your middle finger, with your index and ring finger resting on the medial and lateral margins of the orbital foramen, and then the middle finger drops down on the eyeball with the patient closing their eyes, and it would feel like a marble, as opposed to if you were to then do that right now for yourself, press down with your middle finger on your eyeball, there's a little spring. It feels a little spongy, perhaps like a ripe grape. When you're finished with the palpation, observation, inspection of the eyeball would show a cloudy cornea. The pupil will be mildly dilated compared to the pupil on the other side, and the management for this is urgent referral to the hospital. Obviously, they are not going to be seeing properly out of that eye. You need a relative to take the patient to the hospital, where the doctors there will probably call the ophthalmologist on call. Ophthalmologist on call would rapidly diagnose this and put specific eye drops to help reduce the intraocular pressure. If not relieved in 24 hours, you can have permanent damage to the optic nerve due to the raised intraorbital pressure. Open angle glaucoma or chronic glaucoma is painless and therefore will not present with acute or sudden onset of a painful red eye. Patients with open angle or chronic glaucoma don't really have any complaints until years down the line. They're complaining that they can't really see on the outsides of their peripheral vision. The vision seems to be constricting from the outside, giving what is classically known as tunnel vision. This is real tunnel vision, not metaphorical tunnel vision. Another cause of painful red eye, which is not a red flag situation, is conjunctivitis. Conjunctivitis is the inflammation of the conjunctiva. There are two parts of the conjunctiva. One that covers the anterior portion of the eyeball. This is called the bulbar conjunctiva. And then the other part is going to be underneath the inside of the upper and lower eyelids. It's one continuous layer of cells, and you would find inflammation of both the bulbar and the palpebral conjunctiva. So you're going to look in the eye, you're going to see the redness of the conjunctiva surrounding the clear cornea, and then you're going to pull the lower eyelid down, and then you're going to see, oh, there are several dilated blood vessels, and the inner aspect of the eyelid would look red due to the hyperemia. Most common cause is viral. Uncommon would be bacterial, and in between would be allergic conjunctivitis. The patient would complain of a painful red eye, and if there's itching, it's more likely to be an allergic conjunctivitis. And if there's a crusty, purulent, yellowish white discharge that hardens on the eyelashes, then it's more likely to be bacterial conjunctivitis. If the eye is red and painful but not itchy and doesn't form this crusting, purulent discharge, but there is a swollen lymph node in the preauricular region. There is a lymph node there called the preauricular lymph node, and that's where inflammation, infective stuff flows from the eye. Closest lymph node group is the preauricular. If you find preauricular lymphadenopathy that is tender and swollen, then it's more likely to be viral in nature. No labs are necessary. Your role as a primary care physician is to refer this patient to a medical doctor who will confirm that this is bacterial, put the patient on an antibiotic, eye drop, or whether this is allergic, put the patient on an antihistamine eye drop, or if this is viral, just say to the patient, we're going to leave this alone. This is what you're going to do. You are going to put warm compresses 3 times a day, clean, wet cottonwood swabs, and you're going to swab from inside out, throw away that swab. Uh, Another wet swab inside out, throw away that to help remove some of the material. And the third cause of a painful red eye, and also another non-emergency situation, is a sty. This sty is known as a hordeolum. It could also be known as an external sty as opposed to an internal sty, which we will do at the very end. This external sty, otherwise known as a hordeolum, is an infection of an eyelash follicle. So you're going to see a swelling on the margin of the eyelid, and you're going to see that swelling is going to push one eyelash outwards, and the infection is related to that particular eyelash. The most common infective organism is Staph aureus. The clinical presentation is painful red swelling in the margin of the eyelid, not to be confused with a chalazion, which is another word for an internal sty, which, as I said, we will talk about later. The internal sty is painless and not acute. It is chronic, so it starts off as a small swelling, and over the next couple months to a year, that swelling gets larger and larger and is painless unless this blocked gland, and it's a blocked meibomium gland, becomes infected, and then it's going to become painful. Once again, no labs are necessary. The diagnosis is made on the history and the physical examination. Warm compresses 3 to 5 times a day, and a good idea would be have the patient make themselves a cup of tea, and after they've extracted the tea bag, which is still relatively warm, take that tea bag and hold it over on the painful swelling until the heat disappears, and you do that 3 to 5 times a day. Local antibiotics might be needed. So if this, despite putting the warm compresses, does not cause it to resolve or rupture and then drain and heal, you say to the patient, if this is not better within 24 hours, I need you to go see a medical doctor, because a course of local antibiotics might be needed. Okay. Are there any questions at this stage? If there are not, then before we start the next triad, and this is going to be something that I'll repeat over and over and over again after each diagnostic triad, time permitting, I will give you one typical part 2 multiple choice question with one correct answer out of 4. And remember, it could be concentrating on what's the diagnosis, what test is used to confirm the diagnosis, or some other important fact related to the use of a particular lab finding that is going to match the most likely diagnosis. And then the next question will be a typical extended multiple choice question for part 3, which is 2 correct statements or answers out of 5. I am not going to give you the answer. I expect you to work the answer out on your own and meet together with your colleagues and figure out what the correct answer is, or you can go into ChatGPT, plug the question in, ask ChatGPT to give you the correct answer. And in order to enhance the learning opportunity that this type of question is going to offer, ask ChatGPT to explain if you had the wrong answer, why your answer was wrong, and what are the other options, what the other options mean. You just need to be able to craft the um, ChatGPT or AI prompt for you to learn uh, much more from this learning opportunity. Okay, so here are the two questions. This is the diagnostic triad associated with blurred vision. Blurred vision is another serious condition. Could be caused by emergency situations, but the most common causes of blurred vision would be non-urgent conditions. The first of which is a cataract. Cataract is defined as an opacification of the lens. This could be seen as people get older, appears after you turn 70. But if you start to see cataracts before the age of 70, uh, consider the possibility in an adult that is overweight of diabetes. Listen in the history to see if they tell you about polyuria, polydipsia, polyphagia. Make sure you do a comprehensive metabolic panel and check the fasting blood sugar to see if it's over 126 milligrams per deciliter. If this is a child, consider the possibility of the mother having rubella and passing the rubella virus on to her unborn child via the placenta. This is one of the torches complex organisms. The R in torches is for rubella. It gets into the fetal material, can be deposited in the eye or the ear. It is a common cause of congenital cataracts. Another cause of congenital cataracts would be congenital syphilis, which is also the S in the torches complex of infections that are going to be passed from the mother to the unborn fetus. The complaint would be I can't see well out of one eye. I've had my glasses changed 2 years ago. It didn't really improve my vision much. On examination, you're looking at the cornea, you're looking through the hole in the iris, that's the pupil, and just behind that, you're going to see this grayish cloudiness behind the iris. This is diagnostic of a cataract. Refer this patient on a non-urgent basis to an ophthalmologist. Want to confirm the diagnosis, and the ophthalmologist is going to determine whether this is a mature cataract, whether this patient is best a good candidate for intraocular lens. They take out the inside of the lens that contains the cataract and they put an artificial lens inside the lens capsule that remains. Another cause of blurred vision, which is kind of urgent but not an emergency situation, is a condition known as idiopathic intracranial hypertension. You've done this in trimester 3 when Dr. Alatar covered uh, nervous system pathology. Idiopathic intracranial hypertension is a mouthful, but it tells you a number of things. The pressure inside the cranium, so intracranial hypertension, is raised, but the actual cause of this is unknown, hence the term idiopathic intracranial hypertension. So there's an increase in the pressure inside the skull. The cause is unknown. It may be associated with a number of factors, like it is seen more commonly in young overweight females, in females who have had in the past as a child prolonged tetracycline antibiotic use, in patients who have had vitamin A supplements, or it may occur in young female adults on the oral contraception. But really, by and large, we don't know why this happens in a male patient who is not overweight, who is not on oral contraception or any of the other risk factors we've talked about. As I said before, it's more common in females than males, more common in overweight or obese females. And here's the classic presentation of how idiopathic intracranial hypertension presents clinically. Headaches that are worse in the morning. The patient gets up from a good night's sleep and wakes up with a headache. The headache gradually disappears in the afternoon, gone at night, and then the cycle repeats the next day. Most people who have these kinds of headaches doesn't really ring any alarm bells, and they tend to ignore this. However, if they notice a month or two later that when they get up with a headache, they notice that maybe one eye or both eyes, the vision is kind of blurry. And again, if they wait, as the day goes on, the blurred vision would clear up. And if this persists more and more, then is when they're going to come and see a health practitioner. Medical doctors or chiropractors, you have been trained how to use the ophthalmoscope, and any patient who complains of blurred vision, you should use the ophthalmoscope, try and make a diagnosis, and then send the patient out rather than go, I'm just a chiropractor, I know nothing about blurred vision, I have never had any lectures in neuroanatomy or the eyeball, so I'm going to send you off to somebody who knows all of these things. It's not me. I'm just going to try and find a subluxation, remove it, and let your innate do the rest. That is unacceptable. That is not what you are being trained for. So if you were to look in the back of the eye in a darker room, or as dark as possible, because that would allow the pupil to dilate, because you don't have the wherewithal. I don't have in my office drugs to drop in the patient's eye to dilate the pupil. I just turn all the lights off. If necessary, go in the broom closet. Um, if it's a female patient, have your assistant come in with you in case they think you're going to do something to them in the back there. Bring a chaperone along. In the dark room, the pupils will dilate naturally. Look at the back of the eye, and what you're looking at in particular is the optic disc. And if the optic disc has this appearance, and this is a bulging of the optic disc forward into the eyeball, this is called papilledema, and you will confirm that this is in both eyes. Then you know that this is indicative of raised intracranial pressure. If only one eye optic disc is bulging and has papilledema and not the other one, then it might be something more sinister than just idiopathic intracranial hypertension. Refer the patient to a neurologist, not an ophthalmologist. Even though this affects the back of the eye, this problem is not caused by an eye problem. This problem is caused by something inside the skull that is causing the pressure in the CSF that surrounds the brain to become increased. When you send this patient to the neurologist is most likely to order a CT scan or an MRI of the brain. This is an MRI of the brain because it gives you a lot more detail. The image on the left is what the normal frontal view from above is going to look like. You can see the two eyeballs. You can see the dark biconcave lens. You can see the optic nerve coming from sort of central medial and then going medially, and then on the outer parts of the, and I'm hoping you'll be able to see my pointer, this here and that. Those are your recti muscle. That is the medial rectus muscle. That's the lateral rectus muscle. This is the optic disc where it should be. This is the vitreous humor. And that there where my pointer is over is the lens. That's the optic nerve. The optic nerve is actually covered by a thin layer of dura. Remember, the eye is a outward projection from the front part of the developing brain. It's a projection from the telencephalon. And the picture on the right is a patient with idiopathic intracranial hypertension. In this particular one that I'm showing here, that is the optic nerve, and the optic nerve is surrounded by a thin layer of dura, and that thin layer of dura encloses fluid. This is an MRI T2 because the fluid is white in this picture. So the neurologist can look at the MRI of the brain, in particular the optic nerve, and make the conclusion. Or he may opt to do a lumbar puncture and measure the actual pressure in the CSF. The CSF in the lumbar region is connected. There are no barriers to separate the spinal CSF from the cerebral CSF. And this here, white stuff, is CSF. All of that surrounding there is CSF that surrounds the brain and is present between the arachnoid layer and the pia mater in the subarachnoid space. So you can tell what the pressure is inside the brain in the CSF by measuring the pressure in the lumbar cistern with a lumbar puncture. And then the other one, which is an urgent referral. So there are two situations here that would cause blurred vision. This particular one, more urgent referral than your idiopathic intracranial hypertension. This is temporal arteritis. This is an autoimmune inflammation of the arteries, the smaller arteries, especially the arteries that are branches of the either external or internal carotid artery. It may involve other smaller arteries in other parts of the body. This is a giant cell inflammation that tells you this is a chronic inflammatory granulomatous process. Classically presents with blurred vision, but before the blurred vision comes, the patient might have been complaining for days of headache, unilateral headache on one side, temporal headache. Blurred vision is going to bring them into the doctor's office. You are going to palpate the temporal region where they say my headache is here, and you will then be able to identify a tender, swollen branch of the superficial temporal artery. Superficial temporal artery passes in front of the ear here, and then shortly after that, above the zygomatic arch, it's going to break into two branches, a posterior branch and an anterior branch. And here is the anterior branch being inflamed and affected by this autoimmune process. The patient may also complain of multiple pains, polymyalgia in the muscle. So multiple muscle pains that are related to the joints. You would have done in musculoskeletal pathology and examination. Chronic autoimmune condition that is called polymyalgia rheumatica, which occurs in older females. So listen in the history if the patient says, when you say, is there anything else besides the headache on your right side and blurred vision on the same side? It's usually going to be on the same side of the unilateral headache. And they say, yeah, doc, for the last couple of months I've been feeling these aches and pains in my shoulder region, and I'm thinking, yeah, it must be old age arthritis, and in my hip region. And it helps when I take ibuprofen or Aleve, naproxen. That would be uh, indicative of polymyalgia rheumatica. You're going to refer this patient urgently to the hospital. Why? Because one of the branches that could be involved would be the terminal branch of the internal carotid artery. And the terminal branch of the three terminal branches of the internal carotid artery, I know you know two, anterior and middle cerebral, but we often forget about the ophthalmic artery, which comes off the end of the internal carotid artery just after it passes through the cavernous sinus. If you were to have inflammation in the central retinal artery that comes off of the ophthalmic artery, this can cause blindness, and you want to get to the bottom of this before that happens. In the ER, the doctor is going to send blood off. They're going to look specifically at the erythrocyte sedimentation rate, which should be less than 10 millimeters per hour. This one here would be markedly elevated, and the marked elevation, anything over 50 millimeters of mercury, says there's a lot of inflammation here. And the way to treat this as an urgent problem is to put the patient on large doses of steroids, 60 milligrams today. And we're going to keep that for 3 days, and then we're going to tell you, go see the ophthalmologist. And in the meantime, on the fourth day, you're going to cut down your 60 milligrams to 30 milligrams. On the fifth day, you're going to drop to 25, and then to 20, and then to 15. They come in 5 milligram tablets, and by the time the week is passed, they should have seen the ophthalmologist. So make sure they make an urgent appointment with the ophthalmologist, because what could happen is after you taper off the steroids and the steroids are gone and its powerful anti-inflammatory effect is removed, this may come back in a 2 weeks time or 3 weeks time, and the process starts over again. If there are no questions, then I have two questions for you. Okay. Let's look at another complaint. So we finished with the first E in the EENT disorders we are dealing with. We are now looking at the ear. So we finished with the eye. We're now looking at the ear. Most common ear complaint would be earache. Boards may try to confuse you and use the medical term for earache. They may say a young child with, and does anybody remember what is the medical word for pain in the ear or earache? Otalgia. Oto to do with hearing, algia to do with pain. So one of the causes of otalgia or earache is otitis externa. This is inflammation of the external ear canal. The external ear canal begins right here and extends inwards for about an inch and a bit, where it is going to be blocked by a naturally occurring bit of tissue called the tympanic membrane. So anything from the tympanic membrane outwards is the external ear. The external ear is lined by stratified keratinized epithelium, squamous epithelium, with what are known as ceruminous glands, and ceruminous glands will then secrete wax. The commonest cause of otitis externa, inflammation of the external ear canal, is a bacterial infection. However, swimmers are prone to, when they get the external ear canal wet and soggy, and they push their finger or they push something in the ear because it's itching, they may transfer fungi from their fingers to the outer ear, and you have a fungal infection. Classic presentation of a patient with otitis externa is earache. There is scanty otorrhea. Oto from air, rhea to do with discharge. So there's a scanty, not a copious. A copious discharge is going to be seen primarily with middle ear infections, otitis media. So scanty otorrhea, scanty discharge, pain on traction of the ear. What you do is you hold on to this part of the ear, the pinna, and then you pull it upwards and outwards. And when you do that, you actually stretch the skin that is on the outside, continuous with the skin on the inside of the external ear canal. And if the skin of the lining the external ear canal is inflamed, when you pull on the outer part of the ear, it is going to cause problems. Another place where another procedure that may cause ear pain or otalgia is press in front of this here. If you press in front of this, you could do this to your neighbor, because I would want you to see what is going on. When you press in front there, you actually are going to move this, and therefore you're going to move the skin on the anterior aspect of the external ear canal. No labs are needed. You refer the patient to a medical doctor. He's going to examine the ear, confirm that this is an acute bacterial infection. It might actually be a furunculosis, an inflammation of one of the glands underneath the skin there that may need a slight incision after obviously numb this, and then put you on a course of antibiotic ear drops. If he sees a kind of whitish scaly discharge lining the inflamed external ear canal, he might suspect this is a fungal infection. He would be best advised to take a swab of this, send it off to the lab to culture the fungus in a saburad medium, and then put the patient on an antifungal preparation to drop in the ear. Otitis media, inflammation of the middle ear. It is usually viral, but it could sometimes be bacterial, and there's no real way to tell the difference just looking at this. The patient will complain of earache, and when you inspect the eardrum using the otoscope, you will see the eardrum bulging. And if you see a mucopurulent discharge that obscures most of the eardrum, then you could rest assured that that mucopurulent discharge, which is found behind the bulging eardrum, the only reason for that mucopurulent discharge to be seen out into the external ear canal in front of the tympanic membrane or eardrum is because there will be a perforation. And the perforation usually is up in the attic. If you look at this bulging eardrum, you can actually see an air fluid level, and that's the mucopurulent material that is accumulating behind the tympanic membrane. But as I said, once you see mucopus in the outer ear canal, there is a perforation. You can put money down. You can invoke whose law? The law of odds, otherwise known as Sutton's law. Because you are going to get a question about those 4 laws. I will give you a statement and then I will ask you, what is this, um, which law is used in order to make this particular statement? And it would be, what are the odds that you finding mucopurulent discharge in the external ear canal being associated with a perforation of the eardrum? There are 2 tests that you need to be able to do because this will be could be part of your entrance examination into the clinic. You could be tested on this in boards part 2, boards part 3, and I know in the past they have had a standardized simulated patient who pretends that he has had sudden onset of ear ache. They ask you to demonstrate the use of the not the ophthalmoscope, the otoscope, and they will tell you what the findings are, and from there have you identify the most likely uh, condition to cause this particular problem. And they may even ask you to demonstrate Weber's test or bone conduction or Rene's test. So when you do the Weber's test, you place the vibrating tuning fork on the vertex. This is how I remember it. This is how I was taught. It's spelled Weber, but this is a German guy, and the Germans pronounce their W's as V. So my professor would say this is Weber. You put the tuning fork on the vertex, and you say to the patient, now tell me where you're hearing this. And the patient will say, in a situation of otitis media, it is, I heard best on this side, the right side, and it will tell you if you suspected that this is otitis media, it's the right ear to which the Weber's test has lateralized is the abnormal ear, because sometimes it may lateralize to the normal side. Okay, it all depends on what's the cause underlying uh, ear problems to determine whether the test goes to the affected ear or to the non-affected ear. Then you could be asked to do the Rene test where you compare bone conduction to ear conduction, and in otitis media, bone conduction will be longer than ear conduction. The blood test that you could be asked in boards is your complete blood count. You're looking for a leukocytosis, raise in your white blood cell count, and if you see neutrophilia, which is the term for increased number of neutrophils, then it is more likely to be pointing to a bacterial infection. If the predominant white blood cells were lymphocytes, if they were lymphocytes, then it would mean this is a viral infection. But as I said, you can't tell whether it is a bacterial viral just from the clinical examination or the history. Refer to the medical doctor if chiropractic care does not help. These patients often have an upper cervical subluxation. I am not too sure if your chiropractor teachers have showed you how to adjust the air in order to make the eustachian tube drain properly, because the genesis of otitis media, it's usually inflammation of the eustachian tube, which drains the middle ear into the back of the throat. And if you block the flow of air and fluid through that tube, then fluid would accumulate in your middle ear. Then you have superadded infection either by bacteria or virus, and then you have a full-blown middle ear infection. So chiropractic care might help. If it is not helpful, after 48 hours, so you're going to adjust the day, come back tomorrow, we're going to examine you, we're going to look at your bulging eardrum. Is it less bulging? Or if the temperature today is greater than 102 degrees Fahrenheit, or if there is presence of a mucopurulent discharge. The presence of a mucopurulent discharge means your tympanic membrane has ruptured, and you need to be able to deal with that by putting the patient on a course of antibiotics. And then the third cause of earache, having ruled out it is not otitis externa by pulling on the ear, having ruled out this is not otitis media by looking into the ear and looking for either bulging tympanic membrane or mucopurulent discharge, then could this be temporomandibular joint dysfunction? This is a large group of disorders that affect the temporomandibular joint. It could be multifactorial in origin. It could be traumatic in nature. It might be stress related. It might be degenerative. And you're going to be able to tell which is which by if the person says, it started 6 months ago when my angry boyfriend clopped me over the ear on that one side, or I'm having marital problems with my husband or wife, because spousal abuse is not just limited to women. Or it could be in an older patient, evidence of degenerative arthritis in the temporomandibular joint. Patient is going to complain of pain in the ear or refer to the temporal region. And classically, they will say to you, every time I open my mouth, I hear this clicking or popping noise in the ear on that particular side. You can then confirm that the TM joint's function is affected by trying to have the patient put 3 knuckles in the open mouth. I can do that. Most of you should be able to do that. And if they can't do that and they struggle to just have 2 knuckles in there, then the TM joint is going to be dysfunctional. You may want to order a set of x-rays looking specifically at the temporomandibular joint. If you see joint narrowing, osteophyte formation, or subchondral sclerosis, you have the diagnosis of degenerative joint disease. Spinal manipulation can help some patients if it is related to trauma or stress, but I've not seen any proof that spinal manipulation or chiropractic adjustment reducing the inflammation associated with degenerative joint disease. Refer to a dentist or an ENT surgeon if chiropractic care with a spinal manipulation or an adjustment is not helpful. If there are no questions, then I have 2 questions for you. Okay. Welcome back. Today we'll be covering 2 or 3 more diagnostic hubs. So we'll look at nose problems. First is sinusitis. Sinusitis is defined as an infection of one of the nasal or paranasal sinuses. It could be frontal, it could be maxillary, it could be ethmoid, and way behind the ethmoid bone, rarely it could involve the sphenoid sinus. So here is a particular picture showing you the various sinuses. One up at the top here is the frontal sinus. Here is the orbital margin. And below the floor of the orbital margin is the maxillary sinus. And then between and behind the nasal bones would be the ethmoid sinuses superimposed one on top the other, anterior, middle, and posterior, and then behind there, somewhere in this region, hidden by the perpendicular plate of the palatine bone on the vomer, would then be the sphenoid ear sinus. There's also ear sinuses at the back there. These are the mastoid ear sinuses, and rarely do you get mastoid ear sinus infections. In fact, it's actually called mastoiditis, and that is usually associated with a complication of otitis media. Now, the causes of sinusitis could either be viral or bacterial, and typically they present with fever, mild to moderate fever, pain in the face, and tenderness on percussion over the affected sinus. So if you were to percuss in the middle there or on either side above the supraorbital ridge, that would be the extent of the frontal ear sinus. Below the eye, at the side of the nose, if you percuss there, then that is more likely to be, so underneath here, mastoid ear sinus, and then slap bang in the middle underneath where the middle finger is, and over the glabella, which is the smooth hairless part between the two eyebrows, that might be indicative of ethmoidal sinus infections. There is a feature known as decreased trans illumination in a dark room. If you were to shine a light or have a light in the oral cavity pointing upwards, you should see both maxillary sinuses being equally illuminated. Decrease in one amount of light would then be indicative that you have fluid inside there that is obstructing the transmission of the fluid. Complete blood count is going to show again your increase in your white blood cells, and if it is bacterial infection, increase in the neutrophils. If it's allergic in nature, eosinophilic preponderance, or if this were viral, it would be lymphocytes. Patients with suspected sinusitis should be referred to a medical doctor for further examination, and if confirmed, a course of antibiotics. One of the tests that the medical doctor could order is a sinus view. And here is the frontal ear sinus, not equally distributed on both sides. It's more over on the left side here. Here is the normal triangular shape, pyramidal in nature, clear right maxillary sinus, and over here there's obviously cloudy whitish grayish area telling you that there's fluid in the left maxillary sinus, and therefore this is indicative of maxillary sinusitis on the left side. Rhinitis means inflammation of the nasal passages, the lining of the nasal passages. It could be viral or it could be allergic in nature. The classic presentation is a runny nose with a clear or mucoid discharge. If the child, and it's usually a child, is actually having rhinitis in your office, you may actually see them doing this, taking their palmar aspect of their fingers and pushing it up like that. And this is known as the allergy salute. And in the process of doing that, you can see this transverse nasal crease where they keep pushing up their hands up against this stuffed up nose in order to get some relief. Occasionally, you're going to find these double folds of tissue underneath the lower eyelid, and this is called Denny Morgan folds, and those are characteristic of rhinitis, especially allergic rhinitis, which tends to be either repetitive or recurrent. Examination of the nasal passages with a nasoscope would show pale bluish swollen nasal mucosa. CBC, complete blood count, will show leukocytosis and eosinophilia if this is an allergic response, and obviously lymphocytosis if this is a viral rhinitis. Co-manage with an ENT specialist or an allergist if you suspect that this is allergic rhinitis. And then the last of the nasal problems is epistaxis. Epistaxis is just the medical word for a nosebleed. It could be traumatic in nature. You upset somebody, they punch you in the face, break your nasal septum, you bleed. In an older person, one of the uncommon causes of persistent nosebleed would be hypertension, or in a child, one of the first symptoms of acute lymphocytic leukemia is likely to be a nasal bleed. Epistaxis is defined as a spontaneous bleeding from the nose. CBC might be helpful if you are thinking that this might be an early sign of leukemia. But in the office, this is how you manage, and then you teach the patient how to do this if it were to happen at home. Pinch the nose 10 minutes by the clock. And what you're going to do is you're going to pinch the nose right here down at the bottom. So you're going to put your thumb and your index finger and press on the anterior inferior aspect of the nasal septum. There's a very vascular area there known as Little's area or Kesselbach's area, where 5 arteries, either coming from the maxillary artery or coming from the facial artery, that are going to be concentrating in an area of anastomosis just underneath there. And this is, you're going to pinch the nose 10 minutes by the clock. And if after that there is no stoppage of the bleeding, you're going to refer the patient urgently off to the emergency room. No labs are necessary. What the emergency room ER physician is going to do is, with the nasoscope, look on the nasal septum. If they find an active bleeding point, then cauterize this either with chemicals, silver nitrate stick, or with electrocautery. If the bleeding site is not easily identified, they're going to pack the nose with gauze or put in something called a Simpson's catheter, which has 2 inflatable balloons, one at the distal end. When you inflate it, it goes beyond the nasopharynx and stops the tube from coming out. And then the one that is located in the nasal passage, you're going to blow that balloon up, and this is going to compress the active bleeding site. If that does not work, then you call out the ENT surgeon and they would have a look. Also, if this tends to be recurrent, you would then refer the patient to an ENT surgeon for them to examine where exactly in the nasal septum is this bleeding coming from. 95% of all of your epistaxis happen in the anterior inferior aspect of the nasal septum in Little's area. Occasionally, especially with hypertensive patients, the bleed might be at the back of the nose, where it's impossible to actually apply pressure to stop the bleeding. If there are no questions, then I have 2 questions for you. Okay. Let's look at the complaint of the young teenage child of Brian and Maria. She was complaining of sore throat. There are three common or important causes of sore throat that we will go through the differential diagnosis shortly. The first and probably most common is tonsillitis. Tonsillitis is defined as an infection in the palatine tonsils. There are a number of tonsils besides the palatine tonsils. Here are the palatine tonsils between the two pillars, tonsillar pillars, anterior and posterior fold. At the posterior 1/3 of the tongue, so behind the back of the tongue here are the lingual tonsils. Upwards and at the back here, surrounding the openings of the eustachian tube are the tubal tonsils. At the back of the nasal passage, area called posterior nares, you're going to find the adenoids, and then you might find some lymphoid follicles around the posterior pharyngeal wall there. But tonsillitis is an infection of these two collections of lymphoid tissue. It might be viral, it might be bacterial. Then there's a way I'll show you just now how to possibly tell whether this is viral or bacterial, because viral, there's nothing you or I can do except wait and tend the loving care, and within 5 to 7 days it would be better. But if it's a bacterial infection, because you want to avoid possible complications like rheumatic fever and post-streptococcal glomerulonephritis, you should send this patient off to a medical doctor who will then do a rapid strep test in his office and then confirm your suspicions that this is a bacterial infection. So patients will present by and large with fever and sore throat. The tonsils are going to be red, they're going to be swollen, and if this is a bacterial infection, then it is going to have a fibrinous exudate. This is what the fibrinous exudate looks like. Whitish yellow material seem to be plastered onto the anterior surface of the tonsils. If this were bacterial, there's going to be a specific node that is located just below the angle of the mandible. This is called the jugulo-digastric lymph node. And if that lymph node is swollen and tender, and you have sore throat, this is more likely to be a bacterial rather than a viral cause of sore throat. Complete blood count could be ordered. There's obviously going to be a leukocytosis, raised white blood cell count. And if it's a bacterial infection, it is going to be neutrophilia. If it's a viral infection, there will be an increased amount of lymphocytes, aka lymphocytosis. If you suspect that this is a bacterial infection, refer the patient off to a medical doctor. The medical doctor is likely to be familiar with the use of the score called the Centaur score, and the Centaur score is actually developed by a doctor by the name of Robert Center in 1981, and it is a decision-making tool for MDs to determine whether to treat the sore throat with or without antibiotics. And this is the link for the publication. And the Centaur score is made up of the following. The word center, his name, is used as an acronym. C says can't cough. If you have a bacterial infection and your throat is so sore, your body doesn't want to cough because coughing would make the pain in the back of the throat worse. E is for exudate. N is for the jugulo-digastric lymph node being involved and swollen and tender. T is if the temperature is greater than 38 degrees centigrade, and OR is whether the patient is young or old. Younger people, older people, bacterial infections more likely to be problematic. So if the patient is under the age of 15, you add 1 point. If the patient is over the age of 44, you subtract 1 point. And then you count up each of these as 1 point. And you get a score between 1 to 5. If it's 4 or 5, it's recommended that you do the rapid streptococcus throat test, which actively identifies or rapidly identifies the presence of strep pyogenes, and this is indicative of treatment with a course of oral antibiotics. Another cause of a sore throat is a disease or condition known as a quinsy. A quinsy is also known as a peritonsillar abscess. This is not just tonsillitis, inflammation of the tonsils itself, it's inflammation of the surrounding soft tissue that lies in the floor of the tonsils. And it's a soft tissue infection with abscess formation. Quinsy is different from tonsillitis in that tonsillitis is bilateral, quinsy is unilateral. It's going to cause unilateral sore throat. There's going to be fever. There's going to be asymmetric involvement of the cervical lymph nodes. Again, the jugulodigastric, one jugulodigastric lymph node is going to be swollen and tender and warm, and it's going to be on the same side where the sore throat is worse. If you were to look at the patient at the back of the throat, you're going to see only one tonsil involved, not the other tonsil. And that swollen tonsil is going to push the uvula here that I'm indicating with the laser pointed there. It will be pushed to the other side. Because of the narrowing of the oropharynx and the pain, the patient is going to speak like this. This is called a hot potato voice. Imagine you having a piece of a hot potato in your mouth. You don't want to swallow it, but you want to keep it there to let it cool down. This is a hot potato voice. That is what it sounds like. Your CBC is going to show your increased white blood cells, and because most of these are bacterial infections, raised neutrophils or neutrophilia. This patient should be sent off to the ER. The doctor is going to make the diagnosis. Probably call the ENT surgeon unless the ER doctor is familiar with doing this. I am not. I know what the treatment is. I would call my ENT surgeon, and the ENT surgeon would spray the back of the throat with a local anesthetic spray, and after the area is numb, with a scalpel blade that is protected, so only the tip is exposed. The rest of it has a plastic protection, because what you're going to do is you're going to stab this here quickly, allow the abscess to then rupture and then drain out, and that's all you need. Usually once the abscess is drained, the infection clears up, and there's usually no need for putting the patient on antibiotic cover. And then the last important cause of sore throat, especially in a teenager, unlike tonsillitis that it may affect younger children or older people, is infectious mononucleosis. Infectious mononucleosis is caused by the Epstein-Barr virus, which is a human herpes virus type 4 that is spread by exchange of saliva. Teens exchange saliva by kissing each other, and this is how the virus is going to spread from one person to another person. Presentation of a patient with infectious mononucleosis: teenager, fever, sore throat, and if you examine the roof of the oral cavity, this is the hard and soft palate, you may see these petechial hemorrhages, these red dots. These red dots are called Horkheimer spots. Forchheimer spots are not pathognomonic of infectious mononucleosis because you could also see this in patients with rubella. In addition, the patient would have cervical lymphadenopathy, but not in the submandibular area. It's going to be primarily located in the posterior cervical triangle between the midline and the sternocleidomastoid muscle and the inferior border of the trapezius muscle. The inferior border, trapezius muscle? No. I think let's put the trapezius muscle as one of the borders, because I think the inferior border of the trapezius muscle is actually over the back of the thorax. Complete blood count is going to show lymphocytosis because this is a viral infection, and the lab tech may also report that atypical lymphocytes that are called by the pathologists a different name. They're called Downy cells. It's the same. Strange looking lymphocyte, but the pathologist would report the presence of Downy cells. The lab tech will report this is atypical lymphocytes. Either the Paul Bonnell test or the monospot test would be ordered. Paul Bonnell is an older test. Monospot is the newer test. Both of them are heterophile antibody tests. I'm going to repeat that again. Heterophile antibody tests. Heterophile means is that they use other cells besides human cells. Monospot uses horse red blood cells, and the Paul Bonnell, which is the older test, used to use sheep red blood cells. There is no treatment for this. Conservative care, rest is all that is recommended. Occasionally, some of these patients might have a splenomegaly, and therefore it would be important to examine the abdomen for either splenomegaly or hepatomegaly. Both of these are part of the reticuloendothelial system that are targeted by the Epstein-Barr virus. Of these two, the spleen, the splenic enlargement is more important from a precautionary role. Enlarged spleens are more likely to be easily ruptured, and therefore you would want to encourage the teenager not to go back to contact sports, rugby, football, soccer, in case the spleen is still enlarged and it could easily rupture. Not recommending that you do weekly assessments with an ultrasound looking for how large the spleen is and when it goes back to its normal 1 by 3 by 5, 1 inch thick, 3 inches long, 5 inches wide dimensions. What you use as your indicator that the teenager is ready to go back to school and light sports is the presence or the absence of fatigue. Fatigue is a common feature in patients with infectious mononucleosis, otherwise known as glandular fever because it affects the lymphoid glands and other lymphoid tissue. And you use the absence of fatigue to go, okay, I think you are fully recovered, go back. And this may take up to 6 weeks to clear up properly. If there are no questions, then I have 2 questions for you. Okay. Next would be thyroid swelling, and there are 3 important diseases that we're going to go through. The first, which is probably the more common one, is hypothyroidism. which is otherwise known as myxedema in the adult. Hypothyroidism is defined as having a situation where your thyroxine level is low. The thyroid is the only organ involved in the production of thyroid hormones. What happens in the body is that iodine is brought into the thyroid gland, in particular the thyroglobulin content of the thyroid follicles. It is then tyrosinated. It is combined with tyrosine using a thyroid peroxidase enzyme, and then you're going to get MIT, monoiodothyronine, and then 2, and then 3, or 4, and then 3, and then it is excreted or released into the blood. Causes. Most common cause of hypothyroidism, otherwise known as myxedema in the adult, is burnt out Hashimoto's thyroiditis. Hashimoto's thyroiditis is an acute autoimmune inflammation of the thyroid gland. It's a type 2 hypersensitivity reaction in which the body produces antibodies against either the thyroglobulin molecule or the thyroid peroxidase enzyme. The gland is inflamed acutely and then chronically. And then after years of chronic inflammation, the thyroid follicles no longer can produce adequate amounts of thyroxine and you become hypothyroid. Very rarely it is due to a tumor, a benign tumor in the pituitary gland growing. It is not secreting anything, but its size, it grows and grows and grows, and eventually compresses, first of all, the thyrotrope cells that produce TSH, and then other cells that would produce ACTH, prolactin, FSH, growth hormone, LH, etc. But one of the first symptoms or one of the first targets as a result of this slow growing pituitary adenoma is secondary hypothyroidism. Clinical picture, there are about 20 odd possible signs and symptoms. We're only handling a handful of these. There's going to be fatigue because thyroxine controls the metabolic rates in the body, including the basic metabolic rate of the body. And therefore you remove the stimulus and everything just runs down and slows down. You're going to get fatigued, you're going to run out of energy, you become constipated, you put on weight because you're eating a normal amount of food, but because you're not expending it because of the decrease in the metabolic speed of most of your pathways, you're going to put on weight. There's going to be a hoarseness of your voice because in this particular situation, myxomatous material gets produced in specific areas like the vocal cords, like in the carpal tunnel, and therefore one of the uncommon presentations of patients with unrecognized hypothyroidism would be carpal tunnel syndrome, and you got to screen a patient for carpal tunnel syndrome to see if they have subclinical hypothyroidism. In addition to the hoarse voice, the hair becomes brittle, it may fall out, you lose the outer third of the eyebrows there, and you have what is known as Waltman's sign. Now, another term for Waltman's sign is slow to relax deep tendon reflexes, and we will discuss this later when we do a review of important physical signs that have been mentioned during this week's presentation. So Waltman's sign, which is described as slow to relax deep tendon reflexes, either in the biceps or the ankle. Ankle is the one that you are going to use this more to demonstrate this. it's a pathognomonic feature of hypothyroidism in the adult myxedema. Labs should be ordered. You're going to find classically low T3, T4. This is the definition of hypothyroidism. And because of the negative feedback loop between thyroid hormone and TSH and thyroid hormone, if you have a decrease in your T3, T4, there's going to be an increase in your TSH if this is a problem arising from the thyroid gland. And as I said, in America, the commonest cause of adult onset hypothyroidism, otherwise known as myxedema, is Hashimoto's thyroiditis. In addition, you may find antibodies against the thyroglobulin molecule, TGAB, thyroglobulin antibodies. If you find thyroglobulin antibodies in the serum, this tells you that this patient probably had Hashimoto's thyroiditis years ago and was unrecognized. How do you manage this patient? Co-manage with an endocrinologist. The endocrinologist is going to ascertain whether this is primary hypothyroidism, something wrong with the thyroid gland, which is the majority, or is this the uncommon type of hypothyroidism, which is secondary to a non-secreting tumor in the pituitary gland. The opposite of hypothyroidism is hyperthyroidism, and the most common cause of hypothyroidism, hyperthyroidism, is Graves' disease. Graves' disease is a peculiar variety of thyroid dysfunction in which there's going to be excess thyroxine being produced by the affected thyroid gland. Causes, once again, Graves' disease is an autoimmune disorder, and like Hashimoto's thyroiditis, is a type 2 hypersensitivity reaction. So the body produces antibodies against the TSH receptors found in the thyroid gland. But unlike most other type 2 hypersensitivity reactions in which the antibody is going to destroy tissue, this particular one that is produced against the TSH receptors actually sits on the receptors and stimulates the receptors to then cause the thyroid gland to produce more than needed thyroid hormone. The clinical picture is fatigue. The fatigue here is due to a different pathophysiology than the fatigue that is seen in previously discussed hypothyroidism. Here, you are burning a lot more energy, more than you need, and therefore you're going to run out of energy when you actually need it and be fatigued. What is classic for Graves' disease is the bilateral exophthalmos. There's another cause of hyperthyroidism. It's called Plummer's disease. And in Plummer's disease, it's associated with a multinodular goiter. The goiter that is seen in Graves' disease is a diffusely enlarged goiter affecting both lateral lobes and the isthmus equally. So, presence of bilateral exophthalmos, Graves' disease. Diffuse goiter. There's going to be hypertension, and the hypertension is because increased thyroxine is going to cause your heart rate to increase. And remember that formula that we did years ago? You did it at some time. Blood pressure is the product of stroke volume times heart rate times peripheral resistance. If you increase either the stroke volume, the heart rate, or the peripheral resistance on the right arm of the equation, then the blood pressure, which is on the left arm of the equation, will go up. So tachycardia will cause hypertension. It's one of the uncommon secondary causes of hypertension which we will discuss at at another time, probably next week. There's going to be a fine tremor, especially noticed in the hand. What you do is you ask the patient, and if you're looking at me in the class right now, you're going to ask the patient to raise their hands out straight like this, on level with the shoulder. Fingers are going to be straight out, and you might be able to see a fine tremor. If you're not seeing a fine tremor, but you are still suspecting this patient might have Graves' disease because of the bilateral exophthalmos, what I would suggest you do is take a small piece of paper like an index card, put it on the extended fingers, and you will see how that paper will then exaggerate the fine tremor to the point that you can actually see the edges of the paper faintly quivering. Labs to be ordered obviously will be your thyroid function test. T3, T4 will be raised, and TSH would be concomitantly reduced. Also, if you'd ordered specific antibodies, remember these antibodies have two names. They could be called thyroid stimulating immunoglobulins, TSI, or another term for this is anti-TSH receptor antibodies. Either one will do. The lab will know what you're asking for and give you, do the right test and give you the right answer that you're looking for. And like myxedema, hypothyroidism in the adult, the recommendation is that you co-manage with an endocrinologist who is going to determine, yes, this is primary hyperthyroidism, but Graves, or sometimes you can have hyperthyroidism without the bilateral exophthalmos, and that would be you have a multinodular goiter and one of the nodules is misbehaving and producing excess thyroxine. And then the last would be thyroid cancer causing a thyroid problem. Thyroid cancer obviously is a malignancy in one of the lobes of the thyroid gland. It usually does not affect the isthmus or, in this particular case, the occasional pyramidal lobe that is seen coming off from the isthmus. There often is a family history of thyroid cancer. It may be related to post-radiation exposure in a nuclear accident meltdown years later, 20 to 30 years later. Some of these people will present with thyroid cancer. Thyroid cancers are rapidly growing masses that are going to be firm and hard and irregular, confined to one lobe. So here it's the left lobe that is affected, the right lobe is not affected. As the cancer, which is obviously malignant, is going to invade surrounding tissue, it may cause fixation to the surrounding tissue. And if you move the sternocleidomastoid that lies on this, the mass will move. Or if you attempt to move the sternocleidomastoid, you will not be able to separately move the sternocleidomastoid on the thyroid gland. If it invades deeper structures like the recurrent laryngeal nerve or the external branch of the superior laryngeal nerve, the patient might present with hoarseness of voice. Should you suspect thyroid cancer, refer that patient to an ENT surgeon who is likely to then take a biopsy, send it off, fine needle biopsy, send it off to the cytopathologist who will be looking for evidence of malignancy. You should know these terms. If the report says there is obvious pleomorphism, many cells have different shapes and sizes, there's evidence of hyperchromatism, the abnormal cells would have darkly staining nuclei, They may say there's bizarre mitotic figures or prominent nucleoli. These are all signs of malignancy in a biopsy, and then either the ENT surgeon is going to take the thyroid gland out, or he may ask a general surgeon with this experience of doing thyroidectomies to do the operation. Alternatively, you might just send the patient to a general surgeon for them to arrange for the biopsy. And then, if the biopsy is positive for cancer, then follow that with a total thyroidectomy. If there are no questions, then I have two questions for you. Okay. Okay, we have one more diagnostic triad to finish up, and this is a miscellaneous group. The first of the three miscellaneous disorders affecting the eye, ear, nose, and throat area is a relatively common condition called a pterygium. A pterygium is defined as a fleshy growth in the conjunctiva, primarily the bulbar conjunctiva, the conjunctiva that is on the eyeball. Risk factors include chronic exposure to hot climates, dust and wind exposure. It's more common in equatorial environments or tropical environments like in the southern part of the United States. On examination of the eye, here is what you're going to see. A triangular, yellowish conjunctival lesion extending from the medial canthus, that is what the medial inner aspect of the eyelids are called, and it extends towards the cornea. It may, in chronic or severe situations, encroach on the cornea and therefore will cause some fuzziness of vision. If you see this condition and it bothers the patient, then refer them in a non-urgent manner to an ophthalmologist who would look at this, and if it is bothering the patient, would probably recommend surgical removal of this benign inflammatory tissue growth. Another condition in the eye, ear, nose, and throat problem is a thyroglossal cyst. This is a cystic swelling arising from the remnants of the thyroglossal duct. The thyroglossal duct is a pathway through which the tissues embryologically begin, where the posterior 1/3 join the anterior 2/3 on the dorsum of the tongue. So if you remember that at the dorsum of the tongue there's a V-shaped structure that is marked by prominent papillae known as circumvallate papillae, and at the end of that V shape is a hidden hole called the foramen cecum. Foramen means hole, cecum means hidden, and you have this down growth of epithelium that grows through the neck in front of the hyoid bone, below, slightly behind, and then drops down to pass in front of the thyroid cartilage, the cricoid cartilage, and at around the third or fourth tracheal rings embryologically, you would have this duct giving off two buds, a right and a left bud, from which you're going to get the right and the left lobes of the thyroid gland. Usually, what happens with the duct, it disappears completely. Occasionally, remnants of that duct may remain behind in that position below the tongue, above the hyoid bone, in front of the hyoid bone, below the hyoid bone, and then down towards the third and fourth tracheal rings. This will present as a slow-growing midline swelling between the hyoid bone and the thyroid cartilage. That's the most common location for a thyroglossal cyst. And here is how you're going to tell whether that cyst, that cystic lesion that is in the midline, is belonging to the thyroglossal duct and not lymph nodes that could be found in that region of the anterior cervical triangle. You're going to ask the patient to swallow. And if this swelling moves when the patient swallows, you know that it is in some way related to the trachea and the thyroid gland. Next, you're going to ask the patient to stick their tongue out. And if when they stick their tongue out, that swelling moves upwards, it means that swelling is intimately related to the hyoid bone. Because you could do this right now. Palpate your thyroid cartilage in mid-neck. Go up about 2 inches above the thyroid cartilage. You're going to find a C-shaped hyoid bone just underneath your neck. Hold on to it and then swallow. And you see what happens to the hyoid bone. It moves up. Now, because the cystic swelling is attached to the hyoid bone, when you stick your tongue out, it is going to cause the swelling to move upwards. And that's all you need to make the diagnosis. You refer the patient to an ENT specialist or a general surgeon who specializes in operations in the region of the neck. They will probably take an ultrasound of this lesion, and I'll show you what this lesion looks like on an ultrasound, and then schedule a patient for removal, excision of the thyroglossal cyst. And then the last is trigeminal neuralgia. This is a disorder affecting one of the branches of the trigeminal nerve, in which it is suddenly irritated and you have nerve sharp electrical lancinating pain, stabbing pain in one of the divisions of the trigeminal nerve. The etiology of this condition is unknown. It may be triggered by exposure to cold, touch, or stress. Clinical picture: sudden onset of severe excruciating facial pain lasting between few seconds to 2 minutes and along the distribution of one of the divisions of cranial nerve 5, otherwise known as the trigeminal nerve. It is frequently associated with the mandibular division of the trigeminal nerve, so may present with pain in the mandible or pain that resembles toothache. You go get an appointment with the dentist. He's going to tap, and if touch triggers the episode, then tapping the region in that area, the teeth, the molar teeth, is going to trigger this pain, and he's going to go, oh yeah, you got something wrong with the tooth there. Let's take a wing bite film of that particular area, looks at it, he says to his dental technician, let's retake this with a different exposure or a different view. Looks at it. He's looking for obvious signs of decay. And if this is due to trigeminal neuralgia, there should be no concomitant evidence of dental decay. And then he's going to go, I really don't see anything wrong with this. I can't explain this. We're just going to watch this. And I want you to come back again. And if this happens, I'm going to re-x-ray this, no charge to you, and then take it from there. And if it's likely to recur. And if you go back to your dentist, he's going to take another set of x-rays, relook at this and go, nope, you know what I think this is? I think this is trigeminal neuralgia. If the Dentist is aware that chiropractic care might be helpful in the relief of patients with trigeminal neuralgia. He may refer this patient to you, or if you saw this patient originally and there is no evidence of dental decay and you can't make, you and I are not qualified for this. I mean, the closest we can come to this is open your mouth and let me tap your teeth with this metal probe. And if there is nothing there that triggers this, then no, I don't know what this is. But if the diagnosis of trigeminal neuralgia is made and they have the good fortune of sending the patient to a chiropractor, there have been a number of case reports in the literature in the last 30 years where a chiropractic adjustment, especially of the upper cervical, usually an atlas misalignment, is associated with this, and correction of the atlas misalignment usually is associated with good relief. If chiropractic care is not helpful, then you're going to refer the patient to a neurologist. The neurologist has more stuff that he can offer besides just an adjustment. There are drugs. Some of the drugs are powerful anticonvulsants, drugs that are used to treat epilepsy, which kind of dampens the electrical hyperactivity in the nerve. The neurologist may even order an MRI of the base of the skull with a look at the distribution of the branches of the maxillary artery, especially those that are related to the middle cranial fossa. Occasionally, there may be an aberrant location of middle meningeal artery, which passes close by through one of the openings for either the maxillary division of the trigeminal nerve, which is the foramen rotundum, or the opening in the base of the skull through which the mandibular division of trigeminal nerve passes, which would be foramen rotundum. As I said, occasionally there may be an aberrant middle meningeal or accessory meningeal artery that passes too close to the nerve, and this will then put the nerve at risk of being traumatized episodically. Okay. If there are no questions, then I have two questions for you. Okay. All right. So let's look at a summary of the lab tests that were mentioned specifically in the last couple of lectures while we talked about 15 different conditions affecting the eye, ear, nose, and throat region. The first we talked about on a number of times is a complete blood count. We said that the complete blood count might tell you whether the problem, the itis, whether it be sinusitis, otitis media, etc., is caused by a bacterial infection. Bacterial infections will make a statement in the complete blood count by showing you leukocytosis. Remember, that means increased white blood cell count, and neutrophilia, which means increased amount of neutrophils. That is for bacterial infections. If it were a viral cause of the conjunctivitis or the rhinitis or any of the other ites, then you're going to get an increase in your white blood cell count. But the particular white blood cell that is going to be preferentially elevated would be your lymphocytes, and therefore the condition in which there's an increased amount of lymphocytes would be called lymphocytosis. If this were an allergic response causing an allergic conjunctivitis or rhinitis or sinusitis, then again you're going to get a raise in your white blood cell count, but this time it's the eosinophils that are going to be elevated. And if this is inflammation, remember your ESR or your C-reactive proteins are non-specific markers for inflammation. And the condition in which we were using the ESR in particular to help us with the diagnosis was temporal arteritis, an autoimmune giant cell inflammation of small and medium-sized arteries, and an elevation in your erythrocyte sedimentation rate or your C-reactive protein, if you'd order that, will be a marker for this particular disease because the ESR is going to be markedly elevated above 50 millimeters of movement in a hour period. We talked about thyroid function tests in two main situations. We talked about it in myxedema, which is hypothyroidism in the adult, and we talked about it in relationship to Graves' disease, which is hyperthyroidism, specifically associated with bilateral exophthalmos. We did not talk about ordering thyroid function tests if you suspect a patient having thyroid cancer. Thyroid cancer usually does not mess with the thyroid hormone production. So watch out for that nuance if you ever get that in a question. So T3, T4 levels are going to tell me how the thyroid is functioning. If they are lower than normal, this is myxedema, and if they are high, this is Graves' disease. The opposite is the opposite. In looking at these two diseases, myxedema and Graves' disease, and you measure the thyroid stimulating hormone, because there's a negative feedback loop between T3, T4 and your thyroid stimulating hormone, then in myxedema, in which your T3, T4 is going to be low, so T3, T4 low in myxedema, in myxedema, your thyroid stimulating hormone, TSH, is going to be high. Similarly, if your T3, T4 is high in Graves' disease, it would result in a TSH that is low in the same thyroid disease. Then we talked about tests for infectious mononucleosis. One of the older tests, there are actually two, so it's the older of the two tests is the Paul Bonnell test. And remember, and this is the fourth time I am mentioning this, the Paul Bonnell test is a heterophile antibody test. Heterophile means, hetero means other than normal. Phile means loving. So this particular antibody test uses sheep red blood cells instead of human red blood cells. It has a sensitivity of 70% and a specificity of 92%. The more modern test that is still in use is your monospot test. This again is another heterophile antibody test, but instead of using sheep red blood cells, it uses horse red blood cells. This has a much higher sensitivity than your Paul Bonnell and a much higher specificity than your Paul Bonnell, and therefore this is the reason it has supplanted the use of the older test. But I have a feeling boards could still ask you about Paul Bonnell test, and they would expect you to tell them this is used primarily to tell whether the patient has recently or in the past been exposed to the Epstein-Barr virus, which is a human herpes virus type 4. If there are no questions, then I have two questions for you. Okay. Now we're going to look at some physical signs or tests that we've mentioned kind of tangentially, or we might have mentioned directly in the discussion of the diseases that we've covered in this week. 80s pupil, we talked about pupil size. 80s pupil is also known as the tonic pupil. It may also be known as the Holmes 80s pupil, in which one of the pupils is larger than the other. The affected pupil reacts slowly to both light and accommodation, and this is what is going to distinguish 80s pupil from Argyll-Robertson pupil, which will react slowly to light but normally to accommodation. 80s pupil, the problem is in the fibers, parasympathetic fibers that are carried in cranial nerve 3 on its way through the ciliary body to then be distributed to the muscles in the iris, the pupillary muscle. And remember, sympathetic causes the muscles in the pupil to dilate, so it acts on the radial muscles, and the parasympathetic causes the pupils to constrict. Therefore, it acts on the constrictor muscles of the pupil. So constrictor pupillary muscle. And if you then take away the parasympathetic activity, then the sympathetic tone will make that affective pupil larger than normal. This is a benign condition. You note it, you don't bother about this unless it is associated with other abnormal neurological findings, and then you're going to send the patient off to a neurologist to make more sense of this. In the benign situation, it is idiopathic. We don't know why all of a sudden the cranial nerve 3 oculomotor nerve loses the functionality of the parasympathetic fibers running through the ciliary body. Anisocoria is the medical term for unequal pupil size. It doesn't tell you that one pupil, the pupil that is smaller, is the one that is affected, or it doesn't tell you the pupil that is larger is affected. So both 80s pupil and Argyll-Robertson pupil, which will give you unequal size of pupil sometimes, both of these will give you anisocoria. This may be a normal variant because it's present in 20% of the population in which there is no pathology. However, if there is underlying pathology, here are 5 possible causes of an unequal pupil. It could be Horner syndrome, and then you're going to look to see whether there is drooping of the upper eyelid on the same side with a smaller pupil. And you test for whether the skin on that side is lacking the ability to sweat. It could be the Argyll-Robertson pupil. It could be the Aids home pupil. It could be seen, as we talked about earlier in the week, in acute glaucoma where the increased intraocular pressure causes the pupil to dilate in a kind of mid position. Or it could be evidence that cranial nerve number 3 has been damaged, and is usually associated with some space occupying lesion in the brain close to the middle cranial fossa, um, where the pathology might be. Arcus senalis would be seen in the older population. So while you might be examining an older patient who complains of blurred vision and you see the cloudiness behind the pupil, you may also have noticed that there is this grayish silverish ring around the edge of the cornea. That is called arcus senalis. It is seen with normal aging if it is present in a patient over the age of 40. However, if the patient is under the age of 40, the patient might be overweight, the patient might have mild hypertension. You may want to order the lipid panel looking specifically at the low density lipoproteins and the cholesterol values, because arcus senalis, when it occurs before the age of 40, is indicative of the possibility of high cholesterol. And therefore, you see this in a younger person, you're going to do a test for screening purposes. Remember, 2 weeks ago, we talked about the 4 reasons for ordering tests. And I'm doing this because repetition, repetition, repetition is good for the chiropractic student's soul. The first important reason for ordering a blood test is I know what the diagnosis is. I want to confirm this. So I think this is diabetes mellitus. I'm ordering the fasting blood sugar. I think this is hyperthyroidism, in fact, Graves' disease. I'm ordering the thyroid function test, T3, T4, TSH, and antibody test, including the thyroid stimulating immunoglobulin test. If this were another disease that we talked about and we go, yeah, this looks like Cushing's because of the moon face, then I'm ordering serum cholesterol at a particular time during the night, 10, 11 o'clock at night. We talked about another cause of anisocoria. This is Argyll-Robertson pupil, where one or both pupils might actually be small and irregular. The affected pupil will not react to light, meaning when you shine a bright light in that one eye, the pupil does not automatically constrict, which would be an expression of the activity of the parasympathetic system. It remains dilated, but when you ask the patient, look at my finger placed 18 inches in front of you, and then you move your finger closer to the patient, and as the patient's eyeballs converge, if you look at the size of both pupils, you see as the eyeballs converge medially, the pupils are going to get smaller and smaller, and that's the accommodation reflex in which the pupils constrict. When one of the pupils does not constrict with light, but constricts with accommodation, then this is an Argyll-Robertson pupil. The Argyll-Robertson pupil is due to damage of the parasympathetic fibers that are coming from the Edinger-Westphal nucleus, which is located in the midbrain. So please remember that. Argyll-Robertson pupil damage to the Edinger-Westphal nucleus, which is the nucleus that carries parasympathetic to a certain portion of the region of the head. There are 3 causes that you need to be aware of. 1 is tertiary syphilis, 2, diabetes mellitus, and 3, multiple sclerosis. And then you're going to definitively, if you suspect either of these, you're going to be ordering your VDRL screening test for syphilis, and if that is positive, reflects to your fluorescent treponemal antibody absorption test, FDA-ABS. If this were diabetes mellitus, you order a comprehensive metabolic pattern. You're looking for fasting blood sugar greater than 126 milligrams per deciliter. And if this is multiple sclerosis, you're ordering an MRI looking for periventricular patches known as Dawson's fingers in the brain, and you're looking for similar grayish-white patches around the central canal of the spinal cord when you do MRI of the spinal cord. We talked about doing the Rene test and the Weber test when we suspect that there's going to be a problem with bone conduction versus air conduction or vice versa in this particular test, which is going to help you to differentiate. Am I dealing with otitis media? Am I dealing with otitis externa? Am I dealing with an inner ear problem where the vestibular cochlear nerve is damaged permanently because of drugs? You place the vibrating tuning fork on the mastoid process of the ear in which you are going to be testing. The mastoid process is behind and below the ear. You're going to put the tuning fork on level with the ear canal. It is vibrating, and you say to the patient, please let me know when you no longer hear the sound. You may want to time this. It is usually between 15 to 20 seconds, and that would be the length of bone conduction. With the same vibrating tuning fork, so you're not going to stop it and bang it again. You're going now to take it off of the mastoid process, put it 1 inch away from the ear that you are examining, and ask the patient to let you know when it's no longer being heard. And that would be then a measure of the air conduction. In a normal scenario, you vibrate the tuning fork, ping, you put it on the back of the ear, and it would go for approximately 15 to 20 seconds. You still take that same vibrating tuning fork and you put it outside the ear canal. They should still be hearing it. And if you can still hear it after you've removed it off of the bone, then air conduction is greater than bone. This is what is called a positive Rene test. This could indicate that air is normal, or there might be a sensorineural hearing loss in that ear, because if you were to, let's pretend this patient has damage to his, we're doing the left ear, damage to his left vestibulocochlear nerve. Put it over the mastoid process, and within 5 seconds, the patient says, I no longer hear this. And you go, okay. And then you take the same vibrating tuning fork and you put it next to the external ear canal, and the patient says, I don't hear that, or I hear it slightly and it's gone. Then it may mean that ear is damaged. If the opposite happens, where air conduction is less than bone conduction, then that's a negative Rene test, and that is seen in otitis media. So in otitis media, first ping is over the mastoid ear process. Ping! 15 seconds. Pull it next day and they don't hear that. It means air conduction is less than bone conduction. The normal is ping over the mastoid process. Take it off when it stops. Put it next to the ear. You still hear the maybe for another 15-20 seconds. So please bear in mind what constitutes a positive Rene test and a negative Rene test. And a positive Rene test might be normal or might be indicative of sensorineural hearing loss on the affected side. The Weber test, remember I said to you, even though it's spelled Weber, it's spelled Weber, like in the, I don't know if you guys have Weber Braais here in South Africa. Weber Braais were the thing for barbecues on special weekends. Weber, you put the vibrating tuning fork on the vertex of the patient, the top of the skull. You're going to ask the patient, where is the sound heard best? You don't say to the patient, tell me which ear are you hearing this louder. No. Which ear is it sounding the best? And you will see them listening, and their eyes are going to go in a horizontal fashion. Left ear, left ear, and then they're going to go, I'm hearing it in both ears. That's good. That's normal. If they go left, right, and they go back and then go back to the right and go, I hear it more in my right ear than that's an abnormal Weber test. An abnormal Weber test means this, and please be very careful with how you hear this and remember this because you need to understand this. So, are you listening? When a Weber test lateralizes to one ear, there's a problem with one ear. It doesn't say to you, oh, it lateralizes to my right ear, therefore the ear that has the problem is my right ear. The problem could be in the left ear. It could be either conduction deafness or sensorineural deafness. So let me demonstrate this by asking you to do the following. Um, Make the sound in your head for a couple of minutes and tell me if you hear this in any ear more than the other. You shouldn't. If I'm assuming everybody here is normal, and I know that's a bad assumption to make, I might be making an ass of myself only, not me and you. So you're normal, you hear it in both ears. Now, here's what I want you to do. Don't do it until I say start now. You're going to take your right index finger and stick it in your right external ear canal. Don't do it now. Once you stick it in the external ear canal, no sound is coming through the ear. And any sound you are going to hear in that particular ear is going to be coming via bone conduction. So before you do this, think about this. If I were to stick my finger in my right ear and make the noise or might be a better sound because that's a deeper sound. If I had fluid in my middle ear, so the problem is in my right middle ear, where would the sound lateralize? So then think about this, and if you've answered, the sound would lateralize to the ear that is blocked up. So that would be the abnormal ear. You would be absolutely correct. So let's do that right now together. If you were to plug your ear up with your finger, make the sound, you would hear. All right, take your finger out of your ear now so you can hear me clearly. Sorry, should have told you that. If when you plugged your finger into your ear and made that sound, you heard the sound lateralizing to the same right ear, it meant that your right ear was where the problem is. Okay, so if you had a conduction loss, the air conduction loss, not just conduction, air conduction loss, you would hear the sound louder in the affected ear. Good. Now, work with me here. Suppose you were completely deaf in the right ear and you made that or sound. Which ear do you think you would hear that sound in? And if you said to me in the normal ear, which would be on the left side, you would be correct. So abnormal Weber test, which lateralizes the sound to one ear, does not tell you that the problem is in that one ear. It could be in the other ear. So all an abnormal Weber test means is that you have a problem in one ear, nothing else. By convention, I'm sure your teachers would have told you, if you do your Weber before you do your Rene test. If you do your Weber the, and it lateralizes to one particular ear, whether it be the right or the left, go to that ear in which it lateralizes because there's a greater chance of the problem being in that ear. And why do I say that? So if we put on a scale hearing loss, and on the right scale balance, we put otitis media, which is the classic cause of air conduction being less than bone conduction, and we put over in the left scale pan uh, damage to the vestibulocochlear nerve by drugs. Which do you think is more common in the general population? Nerve deafness or a conduction deafness? And the answer would be it is more common to have a conduction deafness. So by default, and this is where I think the problem arises. You do a Weber, it lateralizes to the right ear. You go and examine that ear and you find something that is wrong. You go, yeah, Weber tells you if it lateralizes to one ear, the problem is in that one ear. No, it doesn't. Okay, but just by the law of odds, you're more likely to be correct, but not absolutely 100% correct. Okay. And then there is Voltman's sign. Voltman's sign, which, as I said previously, otherwise known as slow to relax deep tendon reflexes. When I learned this a little more than a half a century ago, yeah, I'm that old, if you're listening to this again, um, this is what we call this Voltman sign. And then 40 years ago, they said for the medical fraternity in medical education, we're trying to get away from using people's names for tests and diseases. So instead of calling this Voltman's sign, we're going to call this retarded reflexes. Sure, no problems. The English European Society have no problems with the use of the word retard or retardation. Try that in the United States in the 1990s. Nope, can't use the word retard, doc, because retard is actually saying the patient is stupid, is an idiot, etc., etc. So American students did not learn that Voltman's sign could also be called retarded deep tendon reflexes. So over the years, for America, it came to Voltman's sign being otherwise written up for boards as slow to relax deep tendon reflexes. It is best demonstrated using the ankle reflex. And the reason for this is that there's decreased nerve conduction and concomitant muscle contraction that is seen best in the relaxation phase of the deep tendon reflex and is seen primarily in myxedema. So here's an interesting GIF where you can see the doctor tapping briskly the not the patella, the ankle tendon, the Achilles tendon. The foot promptly goes down and then relaxes back in the same speed. I had a student earn 5 bonus points because I said to him, I wish I had the knowledge to manipulate this GIF movement such that I slow down the relaxation phase. So hopefully the next slide you will see this as in the relaxation phase it is being slowed down. So let's cross fingers and look at the one on the left. That's the normal response. Look at the one on the right. It starts off both of them being hit simultaneously, and then all of a sudden you find that the one on the right is not in sync with the one in the left. And I have Nathaniel to thank for helping me to manipulate this image in order to show something different. And bear that in mind. This is not a deep fake. Okay, this is a manipulation of a normal reflex to demonstrate what a retarded deep tendon reflex looks like. Okay. If there are no questions, then I have two questions for you. Okay. Finish up on homework for next week. We will be doing dizziness. We will be doing dizziness. So look at the chapter in next week, download the appropriate keywords, read over the keywords, because you will find that approximately 50 to 60% of the material I have covered so far or will be covering moving forward, you've already been exposed to this. And all I'm doing is I'm repeating it, I'm giving it a little different spin, I'm putting it in a different context, the context of making a diagnosis and using lab results to reinforce, either to confirm the diagnosis or rule out the diagnosis. Any questions? Okay, Kathy, this is specifically for you. If time permits, and I see from the schedule that Rocky shared with me that you have been granted the glorious opportunity of teaching 4 of these hours online and then bringing them back on the final hour as a class together. And I have used this particular activity in the last hour once I've completed. So it's time permitting, once I've completed all of my lecture material. We've done the questions, we've done the lab summary review and the review of the physical signs. I then play the game 20 questions, think aloud. Now, the 20 question think aloud game is a admixture of the 20 question games that I'm sure you're familiar. Ask 20 questions to see if you can guess who, what, or where I'm talking about, and as a child, I used to play this. Is it an animal? Is it a vegetable? Is it a mineral? Or et cetera, et cetera. So it's that childhood question. And then the other one is what is called the think aloud approach to thinking, where teachers will demonstrate to their students in the clinical situation how we experience clinicians get to the diagnosis. We ask questions, and we ask questions not because we want to ask questions and earn money for a consultation. We ask questions that are pretty directed and for a purpose. So I am going to use um, the example of 16-year-old Chloe, the daughter of Brian and Maria Sicalot, and she has been complaining of sore throat. Now, the students are going to be allowed to ask any questions except what's the diagnosis. You will tell them in the end if they don't guess what the diagnosis is, or if they identify by some way of raising their hand or whatever it is you're going to do. I get them to raise and wave the left hand vigorously to tell me they know what the diagnosis is, and I come over, I have them write it down on a piece of paper, and if they get the correct diagnosis, I go, congratulations, do me a favor, Ariana, send me an email so I can add 5 bonus points to your grade book. I don't have a specific column in my grade book because often I don't do this every week. I'll probably get the occasion 3 or 4 times during the trimester to play the Think Aloud game. When I've done this, I've had very good feedback. Why don't we play this every week? And I'm going because every week it's not the same amount of material I have to cover. Some weeks is shorter, some weeks are longer. And then so I add it on to an existing grade, like their exam 1, 2, or 3. Uh, there are a couple rules to this game. When they ask a question, they have to give you or me a valid reason as to why the question is being asked. And then I'll demonstrate that. I tell them the 5 bonus points. The first person who gets this correct gets the 5 bonus points. You can only earn a maximum of 10 bonus points this way per student. This would mean that not every time it's the brightest kid, John, Kim, or Sophia, getting the correct answer is to allow the others to participate in the game. Because when I've done this in the past in the quarter system, half of the class just zones out because they know it's only the top 1/3 of the class that are actually looking for extra points where they what which they actually don't need. Um, and as I said, if they think they have the correct answer, they write this down, they raise their left hand. I come over and acknowledge whether they're correct. If they are incorrect, they hear this sound. You're wrong and you are out of the game. And the reason, and you may have difficulty saying this, because you're a lot more politer than I am. I said, because I don't want you to fall in the trap of making a diagnosis prematurely. Premature diagnosis is just as bad as its bedroom equivalent, unfruitful, unproductive, and a waste of time. Figure that out. You know, when last I did this, it took one male student about 5 seconds to go, oh yeah, good one, Doc. It took him a while and I don't explain these subtle jokes. They can ask you questions related to the history. They can ask you questions related to the physical finding. They can ask you questions related to laboratory findings, but they have to be very specific questions. They can't be double barrel questions like, do you have diarrhea or constipation? Nope, not answering that question. You're going to ask me, does the patient have that? I pretend to be the patient and I go yes or no, depending on whether they tell me why. So they get to see that it's 16-year-old Chloe. So they get free information. This is a young teenager, female, with sore throat. First question. And usually the braver one is going to go, how long have you had this, Zoe? Or it's Chloe. It's Chloe. And I look at them, and you should be able to do this quite good as I did this with you. I look at them straight. I give them the blank LaRose stare. No flicker of the eyelid, no twitching of any body parts. The face is just expressionless. And then their friend says to him or her, you got to tell him why you're asking the question. If they don't, then I say, remember, I'm not answering any question and you don't give me a valid motivation. So why would you want to know how long this patient has had this problem? Because I am thinking if this is a sore throat problem, a problem with a sore throat, a problem with the throat. If this is an acute problem, it might be an infectious condition. If this is a chronic problem, this might more lean into a degenerative problem, an endocrine problem, or a neoplastic problem. Or they may say, it may mean cancer. And I go, okay, that's a good question. That's a good motivation. That is question one. I repeat what the question is for those who probably weren't paying attention. I then give the answer. I said, okay, Joseph, you wanted to know how long Chloe has been having this sore throat. That's a very good question. You've motivated because you said if it's a short onset, this might more be infectious, like tonsillitis. If this were chronic, it might be something with cancer of the throat. Good motivation. She has had this for the past 3 days. Good question. Question number one. And I make a note either on the screen as I'm writing this, or I make the note on a piece of paper. Question number two, and they are getting this. Question number two would be, is there any fever? That's a good question, Sophia. Oh, I want to know if there is a fever, because if there is a fever, it will tell me this is more likely to be an infection rather than endocrine or neoplastic issue. Very good question, Sophia. Very good motivation. Sophia's question was, is there any fever? And she wanted to know, so I'm repetitive because I want them to hear this over and over and over and over, and I could go on over and over. You know what I mean? Um, and she wants to know because fever would more likely put this in the category of an infection, uh, no fever, non-infective process. Uh, Chloe has had a fever. Question number two. Who has question number three? And we walk through this until either somebody waves their left hand or they draw a blank on this. So let's pretend I'm speaking to the class. So we've gone through question number one. What's question number three? Does the voice sound as if it is a sounding like if you have a hot potato in your mouth? Because if you had a hot potato voice, this is more likely to be quinsy causing the disease rather than, let's say, tonsillitis. Excellent question, John. John's question, which is question number three, just in case those of you weren't paying attention, is, does the patient have a hot potato sounding voice? And the answer is no. Question number four. What would I find if I were to examine the back of the throat? That's a good question, but I'm not going to answer that. Could you be a little more specific and tell me what you are looking for? Because you could be looking for a number of things. Okay, doc, I'm looking for the presence of both tonsils being red, swollen, and perhaps an exudate. Why are you looking for this specifically, Jonathan? Because if these were present, doc, I think the answer would be acute tonsillitis. That's a very good question, very good motivation. On examination of Chloe's throat, there is bilateral enlargement of both tonsils. They are red, they are swollen, but there is no exudate. Uh, and somebody in the back there waves their left hand. I said, excuse me. Brianna thinks she has the correct answer. I go over there, and Brianna has written on a piece of paper because at this stage they have no access to no electronic devices. I forgot to say that in the beginning. All laptops, all phones away. All you're going to have is a piece of paper and a writing implement. That's all. Nothing else, because I don't want them to accessing ChatGPT or their notes at this particular stage. So I go over to Brianna, and she has written there. Um, thyroglossal cyst. And I look at this and I go, sorry, Brianna, this is not correct. Wrong. You are out of the game. I go back to the front of the class and we go through question number 5, question number 6, and somewhere along the line, somebody is going to ask about, are there any tiny red dots known as petechiae found on the hard palate? Now they're looking specifically for Forchheimer spots. They tell me that the presence of Forchheimer spots is indicative of um, glandular fever, infectious mononucleosis. That's a good question, good motivation, but I know that not every patient with infectious mononucleosis is going to have Forchheimer spots. Forchheimer spots, when they're present, does not necessarily mean the diagnosis is infectious mononucleosis. It could occur with other upper respiratory tract infections. It could occur in rubella. So I'm going to not deliberately mislead them, but uh, slow them down a bit. Nope. There are no petechiae, otherwise known as Forchheimer spots. Get down to question 10, question 11. Some bright spark says, "Oh, doc, what do the blood tests show?" Again, they get the blank stare. Uh, what specific blood test? A complete blood count. What aspect of the complete blood count you're looking for? Oh, whether there is anemia or infection or this or that, and I'm going, no, I can't give you that information. You got to choose one out of the 10 uh, tests that are included in a complete blood count, and then I will answer this. Pause. They're thinking. Somebody else says, okay, doc, I want to know whether there is an increase in the number of white blood cells. That's a good question. Why do you want to know? Because it will help me if I know white blood cells are up, if there's an infection, or whether there's a leukemia. Very good question, very good motivation. The white blood cell count is up. Good. Another student waves their hand and they think they know what this is. You come over and based on the information, they guess Quincy because they weren't paying attention to the question that John asked previously. Was there any hot potato voice sounding? So Quincy, no, out, you're out of the game. And another student says, I want to know if the lymphocytes are up. Why do you want to know that? Because it will let me know that it's perhaps caused by a virus. They're being very cagey now because they know if they say specifically, um, because I want to know if this patient has infectious mononucleosis, and then everybody else knows because I'm going to have to give them the answer. Yes, the white blood cell count is up. There's leukocytosis. Yes, there's an increased lymphocytic population in the leukocytosis. Another student puts her hand up and she says, can you tell me what's the result of the monospot? And by this time, they're getting into the game, and they follow this because if the monospot is positive, then I know that it is a particular viral infection, and I say the monospot test is, and I wait a while because they're waiting to jump the gun, is positive, and then hands go up, and this the first one. I come over and I go, absolutely correct, Angela. The diagnosis is infectious mononucleosis, and then I will use the time to say, this is great. Would you like to play another game? And then I would randomly choose any of the 15 conditions We've talked about I'll probably choose one in which there is no fever. I'll probably choose one in which there is a thyroid problem. And therefore, they're going to have to go through, is this myxedema? Is this thyroglossal cyst? Is this Graves' disease, multinodular goiter, or thyroid cancer? I usually have fun with them. And if you are in this particular part of the course and would have finished with they would have finished in the first 4 hours, you got time in the 1 hour left that you're going to have actual physical contact with them to definitively play one such 20 question think aloud. Now, at the bottom of the slide, you will see here is the information that if they ask for specifically, you will give them this information. And what I also say to them, and you will probably corroborate this, when they are being tested in boards part 4, they use standardized simulated patients. The standardized simulated patients are coached. They're given a script that they have to stick to. If the student asks you this question, this is your answer, yes or no, or you can elaborate. If they ask a question that is not covered on your script, you must say to the student, sorry, I do not have that information. So if they were to ask you very specifically for X and you don't have that information, mimic boards part 4, if I'm correct, and say to them, sorry, I don't have this information, and explain to them why you don't have that information. It's not on the script that you were left. Okay. All right. If you have any questions, um, I will leave you my contact email address, kyrieessentials@gmail.com, and you can just drop me a note, Kathy, and I will be glad to assist you. All right, you have fun with this. Bye for now.